Welcome to the Deep Dive, the show where we pull back the curtain on some of the most complex and, honestly, consequential topics that are defining our world today.
And today, we are really getting into a foundational question in American healthcare.
We're tackling the role of the Doctor of Nursing Practice, the DNP degree. What is it? And maybe more importantly, is the profession actually using this massive credential to its full potential?
You know, this is really a deep dive into professional identity. It's not just about an academic title.
Right.
We're analyzing what is, I think, a seismic shift in nursing education, a shift designed to produce leaders who are equipped for a health system that is fundamentally new. The DNP is the terminal practice-focused doctorate, and its growth has just been, well, nothing short of phenomenal.
Oh, the numbers are striking. I mean,
Yeah.
if you look at the data from around 2014, there was something like 269 DNP programs,
Yeah.
which had already far surpassed the 134 PhD programs in nursing. And that tells you something, right? It says the market, both academic and clinical, is aggressively moving toward this practice doctorate model.
But that explosive growth, that's where our central tension comes from. It's the friction we really have to analyze throughout this whole discussion.
Which is,
How different, really, in a functional sense, are DNP graduates from their colleagues who hold a Master of Science in Nursing, the MSN? Is this a genuinely distinct new role, or is it just, professional degree inflation?
and for you, the listener, especially if you're maybe considering this path, that ambiguity is absolutely critical.
It's huge.
Anyone who embarks on this journey, you're investing a huge amount of time, a significant amount of money, and just a ton of professional energy. You need to know that the impact of that DNP is going to be worth the investment.
Both for your own career and for the healthcare system you're trying to influence. And that ambiguity, that's the core of the professional journey right now. I mean, our sources are crystal clear on this. You will not find a single universally accepted, separately laid out role description for a DNP versus an MSN. It just doesn't exist yet.
So the vision is being shaped right now.
In real time, by the current generation of graduates and, of course, the educators who are training them.
You know, that kind of dynamic, that uncertain environment, it requires a very specific kind of professional, doesn't it? We're talking about, and this is a quote, rebels, renegades, and trailblazers.
Exactly right. And it really parallels the experience of the pioneers of the original APRN movement. You think of someone like Loretta Ford.
Founder of the MP role.
Right. She faced just immense institutional resistance when she was forging the nurse practitioner role back in the 60s. That same sense of necessary boldness, of pushing past the established boundaries, that's what's required of DNP graduates today as they try to define their own domain.
So the stakes here are incredibly high. The journey for these graduates isn't just about optimizing their own individual careers.
No, not at all.
As the blueprint suggests, the DNP mandate, it has to flexibly serve three main stakeholders at the same time. The profession of nursing itself, the huge healthcare systems they work in, and of course, most importantly, the people who are served by both.
It's a three-legged stool.
Let's start at the very beginning. Why was the DNP degree even necessary? Why couldn't the MSN just continue to evolve to meet these new needs?
It really came out of organizational necessity. The primary purpose was to prepare advanced clinical leaders.
Leaders, not just practitioners.
Exactly. We're talking about leaders who have not just the clinical depth, but also the organizational and the analytical skills to bring about meaningful system-wide change. The goal was improving quality of care, improving health outcomes. The MSN, while it's clinically excellent, was becoming more and more focused just on specialty practice, not on systems intervention.
And there was also this major push for professional parity, which, that's understandable.
Oh, absolutely. The argument was, and it still is, that other major health professions had already transitioned their entry to practice degrees to the doctorate level.
We saw it with pharmacy and physical therapy.
Right. Pharmacy adopted the PharmD, physical therapy moved to the DPT. So the thinking was, if nursing is truly committed to preparing leaders who can stand on an equal academic footing with these colleagues, well, it needed a comparable terminal practice degree. It just makes sense.
But beyond the, let's call it professional politics, the most pragmatic driver was this concept of credit creep. We keep hearing that phrase. What does that actually mean?
Credit creep is that slow, steady inflation of academic credits that you need for a degree. And historically, MSN programs, especially the ones preparing nurse practitioners, were already growing way past the typical master's credit requirements.
Which are usually, 30 to 36 credits?
Around there, yeah. But with all the clinical content, pharmacology, specialty courses, A lot of these MSN programs were pushing into the high 40s, even 50s.
And at that point, it starts to feel less like a master's degree and more like you're doing a doctoral program, but without the right name on the diploma.
Precisely. The DNP was created in part to just provide a proper, standardized academic home for this ballooning curriculum. It formalized the reality that the preparation needed for advanced practice had already, conceptually and credit-wise, surpassed the master's level.
So if we look at this whole educational journey through the lens of what our sources call the ecologic educational framework, where does the DNP fit in?
Okay, so this framework sees the whole APRN journey as a progression of competencies within this complex system. You start with the BSN. That gives you the core competencies for entry into practice, the micro level of patient care.
One-on-one.
Right. Then the MSN builds on that, and it allows you to specialize. Education, administration, or one of the 4 clinical APRN roles.
So the MSN graduate leaves with a very clear clinical identity. They know what they are.
Exactly. They know they're a neonatal MP or an adult gerontology acute care MP. Their whole program is tailored to that specific role. The DNP then builds on that. It's like an advanced version of the whole novice to expert progression, but it's applied specifically to APRN roles at a systems level.
It positions them for leadership within that system.
Yeah. Yes. The whole vision is that DNP graduates are equipped with this doctoral level knowledge to go out and seize system level opportunities, to leverage the credential for policy influence, and to really help transform the workplace.
This brings us to that perennial debate, right? The DNP versus the PhD.
Yeah.
We need to get really clear for the listener on the scholarly focus here.
Right. The traditional distinction was pretty philosophical. The DNP is practice-focused. It's concerned with translating and implementing knowledge in the real world.
Boots on the ground.
Exactly. And the PhD is research-focused. It's dedicated to discovery, often kind of behind the ivy towers, building a program of original research.
But then the AACN, the American Association of Colleges of Nursing, they came in and complicated this. They clarified that both degrees generate new knowledge. It's just in fundamentally different ways.
And this is the crucial nuance. The PhD generates new knowledge through really rigorous research and statistical methods that are designed to be broadly applicable. They're generalizable.
So they're testing hypotheses that should apply across different populations in different contexts.
Yes. Their output is discovery scholarship, finding out something brand new that we didn't know before.
And the DNP's knowledge generation is different because it's all about implementation.
Correct. The DNP generates new knowledge through the innovation of practice change, through the translation of evidence that's already been discovered, often by PhDs, and through the implementation of quality improvement processes. This knowledge is considered transferable. You can adapt it and move it to other settings, but it's not generalizable in that statistical, foundational discovery sense.
Okay, let's make this practical. If a PhD is looking for funding, they're probably writing an NIH R01 grant to test some new biological mechanism. What's the DNP scholar writing a grant for?
The DNP scholar should be an expert at writing program grants. So think about federal opportunities from places like HRSA or private foundation grants. These grants are explicitly aimed at implementing evidence-based programs, at addressing health disparities, and improving specific health outcomes in a defined community. It's all about dissemination and implementation science.
So the DNP project is systemic, it's immediate, it's practice-based?
It has to be. The focus is on the application of scholarly methods, quality improvement cycles, evaluation methods. It's all about getting evidence from the journal page into the patient's care plan. That's the DNP's unique contribution.
So we know all DNP programs are built on this framework, the 2006 Essentials of Doctoral Education for Advanced Nursing Practice. This is the blueprint. We really need to dissect how these essentials actually shape what a DNP is supposed to do.
Absolutely. Analyzing the essentials is critical because they are, in effect, the profession's promise for what the DNP graduate will be able to do when they finish.
Okay, let's start with the first one. Essential I. Scientific underpinnings for practice. This is the clinical foundation, right?
It is. This essential covers the traditional core science for advanced practice, advanced pathophysiology, advanced pharmacology, and advanced health assessment. And then organizations like NONPF, the National Organization of Nurse Practitioner Faculties, they strongly suggest integrating things like genetics and genomics into this.
But this is where that split we talked about earlier creates a real challenge, the BSN to DNP versus the postmaster's DNP students.
It creates a major disconnect. A BSN to DNP student, they absolutely need this content. But the vast majority of DNP students, they come in with an MSN. They've already successfully completed all of this core science content to become licensed APRNs in the first place.
So if they already have it, what advanced science are they adding at the doctoral level? This is where critics say the degree might be a little shallow.
And that's the heart of the debate. Most postmaster's DNP programs, they generally do not require specific additional doctoral level science content. There are some exceptions, of course.
So are we suggesting that the depth of science needed for DNP practice is the same as for MSN practice?
Well, the argument is that the DNP degree is meant to build leaders who translate science, not necessarily discover it, which is the PhD's job. But the lack of specific advanced science in most postmaster's curricula, that remains a real point of contention. It raises the question of whether the DNP is clinically advanced enough to truly disrupt practice.
Or if the advancement is purely in systems thinking and organizational knowledge.
Exactly.
Okay, let's shift to that systems leadership component, because that's arguably the DNP's biggest differentiator. Essential 2, organizational and systems leadership, and Essential 4, information systems technology.
Essential 2, this is really where the rubber meets the road for systems change. DNP graduates have to develop and evaluate care delivery approaches by integrating scientific, organizational, political, and economic sciences. It moves them from being just a provider in the system to being an architect of the system.
Our source material flagged a concern here, the ethics gap. Tell us about that. Why is integrating ethics across the curriculum instead of having a dedicated course seen as a problem?
The concern is dilution. When content like ethics, political ethics or organizational ethics, loses its identity as a singular course taught by an expert, the content can get de-emphasized. It might get a superficial mention in a leadership course, but that's it.
And why does a DNP leader need such strong, focused ethics training?
Because systems leaders face these huge, large-scale ethical dilemmas that are very different from individual patient dilemmas.
Like what?
For example, a DNP administrator might face pressure to limit referrals or ration costly resources to meet a budget. That requires a very high-level understanding of ethics. Or think about implementing a new AI tool. It might improve efficiency, but it could also introduce bias into diagnostics, making health disparities worse. A DNP leader has to be the ethical compass for the whole system. That needs dedicated training, not just a passing mention.
That makes a really compelling case for making ethics a standalone essential. Okay, what about Essential 3, technology and informatics? This sounds like it's all about data fluency.
It is. This essential says DNP grads have to be able to design, select, use, and evaluate programs for outcomes monitoring. And crucially, they have to be leaders in resolving the ethical and legal issues that come with technology.
So what does this mean for the DNP's role with data? Were they supposed to become informaticists?
No, not full-fledged informaticists, but they have to become sophisticated data consumers and, maybe more importantly, translators. They need to bridge the gap between the frontline clinicians and the IT analytics teams.
So it's about strategic stewardship of data.
Exactly. The DNP isn't running the statistical model, but they have to know which clinical questions to ask that the data can answer. They have to be comfortable talking to analytics teams about big data and then translating the results back into actionable, evidence-based decisions for their staff.
And finally, Essential 3, clinical scholarship and EBP, or evidence-based practice. This seems like the engine for change.
This essential really defines the DNP as the leader for evidence-based practice translation. Their primary scholarly method is taking evidence that's been discovered by others and translating it into new, impactful initiatives.
So the big DNP project isn't just an academic hoop to jump through. It should be a blueprint for a real-world change.
It absolutely should be. For example, a DNP student might identify a big problem with hypertension control in a rural clinic. Their project wouldn't be to discover a new hypertension drug that's PhD work. It would be to design, implement, and evaluate a transferable, evidence-based remote monitoring program to improve outcomes in that specific population.
Okay, so we've laid out the vision and the curriculum blueprint. Now, let's pivot to the real world. We have findings from a 2015 national survey of DNP graduates, almost 700 of them. This gives us a crucial snapshot of whether that vision is actually translating into reality.
Right, and the first thing to note is the demographic profile. It was 88% female. And importantly, around 75% identified as working in academia after graduation.
Wow, 75%.
Yeah, which highlights the immediate impact the DNP had on the nursing faculty shortage. But the survey didn't clarify how much of their time was clinical versus academic.
But the core finding, the one related to practice activities after graduation, This is where we find some real professional friction.
This is the data that really challenges that initial DNP mandate. More than a quarter of all respondents reported no change in their professional activities after getting the DNP, and this was across 11 of the 14 domains they surveyed.
No change.
This is what we call the practice gap. It suggests that those big organizational leadership roles that the Essentials envision, they just aren't universally or immediately available to graduates.
Let's break that down. What were the areas of minimal change? The expected systems leadership roles that just aren't materializing right away.
The data points are pretty stark.
Yeah.
So if you look at organizational and administrative roles,
Yeah.
over 52% reported minimal or no change in functioning as an administrator. Over 58% reported minimal or no change in developing or implementing information systems, a core essential for competency. Over 55% reported minimal or no change in initiating a program to address disparities. And over 50% said there was minimal or no change in initiating an organizational level change initiative.
So if the degree's primary promise is systems leadership, for half or more of the graduates are saying nothing's changed in those functions, are we asking clinicians to spend thousands of hours and dollars on a credential that employers aren't ready to pay for?
That is the billion-dollar question, isn't it? The degree prepares you to be a change agent, but the organization itself may not be ready to receive you as a change agent.
So why is there a gap? Is it just institutional resistance?
It's a combination of things. First, you have job descriptions that were written 10, 15 years ago. They're slow to update. HR systems often don't see the nuanced difference between an MSN and a DNP. And second, there is often resistance or just confusion from the existing leadership physicians, hospital administrators who don't fully get the DNP scope. They see an APRN and they default to clinical expectations, not executive ones.
So you have the skills, but you're blocked by the hierarchy or just the sheer volume of clinical work.
Exactly. You're hired for your clinical revenue-generating capacity, and that often pushes the system leadership skills to the back burner until you can actively negotiate for a dual role. The DNP graduate has to create the opportunity to lead.
But the survey wasn't all bad news. It also showed clear, undeniable areas of significant impact. So where did DNP graduates say they were excelling?
Okay, so the DNP preparation clearly solidified their core clinical scholarship identity. This is where it really shined.
Okay. Graduates
reported doing these core functions much more often since they graduated. For instance, actively incorporating evidence in practice. A resounding 72% said they did this more or considerably more often.
That's a huge number.
It is. 65% said they were translating evidence into new practice initiatives more often. And almost 55% reported participating in interdisciplinary teams more often.
So the degree is overwhelmingly successful at creating a clinically grounded, evidence-based scholar and a collaborator.
That's the ultimate takeaway. The DNP Essentials clearly integrate into the thinking processes of the graduate. They build this foundational mindset for translating evidence and approaching complex problems in a systematic way. That is a massive win for patient quality and safety.
But the practice decisions they make are still constrained by the real world.
They are. I mean, your day-to-day decisions are influenced by immediate factors, right? Institutional guidelines, system limitations, financial pressures, human dynamics. The Essentials give you this internal compass, but the external dynamics, they dictate the speed and the scope of the change you can actually pull off.
We have to remember that the DNP was created as a direct response to a changing healthcare landscape. The old fee-for-service model is, well, it's dying. It's being replaced by value-based care, VBC. And that shift demands system leaders.
It absolutely does. The shift to VBC means that financial reimbursement isn't just about the quantity of services anymore. It is intrinsically tied to quality and measurable outcomes. If you can't prove quality and outcomes, you don't get paid, or you get paid less. That fundamentally changes the entire game.
And VBC is encapsulated by that famous economic equation.
Yes. Value equals, more or less, quality plus outcomes divided by cost. If a nurse administrator, especially a DNP-prepared one, doesn't internalize and act on that equation, they simply cannot lead effectively in a modern healthcare organization.
So the DNP leader's role becomes one of strategic stewardship. What does that mean in practice?
Strategic stewardship is the DNP's unique ability to link those micro-level clinical processes to the macro-level financial and quality outcomes.
Give me an example.
Okay, a DNP in an acute care setting leads an initiative to standardize patient education for COPD. Their strategic stewardship means they can track how that specific clinical process, the micro-level action, translates into reduced readmission rates, the macro-level outcome. And that helps the hospital secure bonus payments tied to VBC metrics. They connect the dots.
And to deliver that value, organizations have to become what are called high reliability organizations, or HROs. How does a DNP executive drive that cultural change?
HROs demand a robust culture of safety, what we call a just culture, where staff feel safe reporting errors without fear of being punished unfairly. The DNP executive has to actively cultivate the 5 principles of HROs.
Let's run through those principles, starting with the first 2.
Okay, first is preoccupation with failure. This means you treat near misses not as lucky breaks, but as critical opportunities to improve your systems. You dig into why it happened.
And the second.
Second is a reluctance to simplify. Healthcare problems are never simple. The DNP leader has to avoid single-cause explanations and understand that breakdowns are usually a result of interconnected system failures.
Okay, what about awareness and resilience?
The third is sensitivity to operations, which is just maintaining constant situational awareness of what's happening on the front lines. The DNP leader can't be so removed in the executive suite that they lose touch. The fourth is commitment to resilience, making sure the organization can bounce back quickly from errors.
And the final principle, deference to expertise, that seems like the most critical one for breaking down old hierarchies.
It is the defining feature. It means the organization has to listen to the person with the most knowledge or the most recent situational awareness, regardless of their rank or title. A DNP leader cultivates this by, say, structuring daily safety huddles to explicitly give a voice to the frontline tech or the bedside nurse, even if the CEO is in the room.
This high-level systems perspective ties directly back to Essentials V, 6, and 7, policy, collaboration, and population health.
Right, and managing health at a population level is central to modern models like accountable care organizations or ACOs.
Which are all about managing covered lives.
Exactly. The DNP role there is heavily focused on preventative care, sophisticated chronic disease management, and system-wide efforts to keep entire populations healthy and out of the hospital. It's about moving beyond episodic acute care and into long-term strategic health management.
But for DNP innovators to really do this, to realize the full potential of these essentials, we have to talk about the political reality that holds them back. The need for full practice authority.
This is a massive ongoing barrier. I mean, despite the level of education and the clinical rigor, only about a third of U.S. states permit full practice authority for APRNs. In the other 2/3, DNP graduates have to operate under these restrictive collaborative agreements that can hamstring their ability to open a practice or admit patients without a physician's sign-off.
And if the U.S. is serious about bridging the huge gap in primary care access, this has to change.
It has to. Every healthcare provider needs to be allowed to practice to the fullest extent of their knowledge and competence. This political constraint limits the DNP's ability to be the disruptive innovator they were educated to be.
Speaking of disruptive innovation, let's explore that bold vision for the DNP practitioner, the one that echoes the futurist thinking of someone like Clayton Christensen.
Right, so Christensen's model suggests that lower-cost, high-volume providers like APRNs will gradually disrupt the precision medicine portion of the physician's practice. This means physicians should focus less on managing common high-volume disorders, which others can handle cost-effectively, and instead focus on the most complex procedures and the next frontiers of science.
And the DNP, with systems training and high-level EVP skills, is uniquely positioned to lead this disruption.
They are. I mean, the boldest vision out there suggests creating primary care practices made up completely of DNP-prepared practitioners, what some are calling doctoral advanced practice nurses, or DAPNs. This would be a team of NPs, nurse midwives, and clinical nurse specialists, all operating with full autonomy.
That model would be incredibly competitive financially.
Critically competitive. We project that these doctoral nursing practices could negotiate highly favorable contracts, especially for vulnerable populations or in medically underserved areas. Think rural clinics, urban health centers, correctional facilities, places where physicians are often reluctant to practice.
Okay, let's shift gears to academia. We mentioned earlier that the academic impact of the DNP has been explosive.
It really has. More than 50% of new DNP graduates say they're interested in getting a faculty appointment. And this is vital because the industry desperately needs faculty with doctorates to maintain accreditation. We're seeing DNP graduates move rapidly into leadership roles like dean, chair, or program director.
But this surge, while it's filling a need, has also created a real faculty identity crisis in academic circles. Is a practice-focused degree really an adequate foundation to teach compared to a research-prepared colleague?
And that is the source of significant controversy and tension within universities. Some traditionalists argue that PhD faculty offer a deeper foundation in theory, but the data suggests the DNP offers superior clinical relevance. An NLN survey found that while research faculty scored a bit higher on curriculum development, DNP faculty ranked notably higher on clinical skills.
Which makes sense. Nursing is a practice discipline.
It is. But the system imposes this crippling workload challenge, the traditional tripartite mission of teaching, scholarship, and service. And it's far heavier for DNP faculty.
Why is it heavier for them specifically?
Because DNP APRN faculty must maintain clinical practice and certification. It's not optional, it's a requirement for their license and often for the university. They have to do this on top of all the standard academic requirements, developing courses, advising students, sitting on committees, and producing tenure-worthy scholarship.
Our sources identify 3 specific paradoxical scenarios for failure for DNP faculty on the tenure track. Let's walk through these because this seems like a critical structural barrier.
Okay, scenario A is the most straightforward, exclusion from the tenure track. Some institutions just refuse to place DNP graduates on the tenure track because they didn't do a traditional research dissertation. This immediately relegates them to lower paid, non-tenure track clinical educator positions.
Okay, and what's scenario B? This is where they're set up to fail even if they do get on the tenure track.
This happens when the DNP grad is required to produce scholarship at a level equivalent to their PhD colleagues. So, generating generalizable discovery research and getting federal funding, plus maintaining a rigorous clinical practice. It's functionally impossible.
They're essentially being asked to hold 2 full-time jobs.
Precisely. And the standards for DNP scholarship, which should be focused on implementation science and QI, are often misunderstood or just flat out discounted by tenure committees that are dominated by PhD faculty.
And scenario C.
Scenario C is when the DNP graduate is simply unprepared for the research or scholarship parts of the faculty role. If their DNP program focused too heavily on the clinical side without enough training in grantsmanship or advanced statistics, they might have a really superficial understanding of what's required for promotion.
So to address this whole mess, this unsustainable workload and identity crisis, a new model is clearly needed.
Right. The proposed solution is differentiated roles, focusing on individual faculty strengths rather than forcing everyone into the same mold. The model suggests 3 paths: the nurse scientist with a research focus, the educator-clinician, and the clinician-educator.
And the DNP prepared educator is perfectly positioned for those last 2 roles.
They are. The clinician-educator role is all about integrating classroom knowledge with direct current clinical practice. Their scholarship is defined by practice, innovation, and curricular development, making sure the education stays relevant.
The DNP educator is also seen as the key to implementing fundamental transformation in how nursing is taught, based on that landmark Carnegie Foundation study.
Right, that 2009 study, Educating Nurses, a call for radical transformation. It recommended 4 crucial shifts that the DNP educator is ideally positioned to implement because of their systems-level, practice-based training.
So what are those 4 shifts?
First, shifting from just covering abstract theory to emphasizing a sense of salience and direct application to practice. Second, moving from a sharp separation of clinical and classroom teaching to the integration of the two.
The third shift moves beyond just critical thinking.
Yes. Third is moving from focusing only on critical thinking to emphasizing clinical reasoning and clinical imagination. Clinical imagination is the ability to envision how care could be delivered differently and better. It's the core of disruptive innovation.
And the final shift is about professional identity.
Fourth, shifting from simple professional socialization to emphasizing formation, the deep ongoing development of a professional identity that's rooted in ethical practice and systems accountability. All of these shifts demand a deep, current understanding of clinical reality combined with systems thinking, the exact combination the DNP is designed to provide.
This level of growth requires what educators call transformative learning in the student.
Transformative learning is the gold standard. It results in a fundamental change in your worldview. It leads to more perceptive, complex thinking and the ability to appreciate multiple perspectives. And this, in turn, helps you develop metacognition.
Metacognition, thinking about thinking, but applied to practice.
It's the self-reflection on practice decisions and outcomes that allows a DNP to recognize the unknown unknowns in a system, Those consequences you couldn't immediately foresee and mitigate them quickly. This high-level reflective practice is what sets the doctoral leader apart.
This has been an incredibly intensive analysis of the Doctor of Nursing practice degree. Let's try to synthesize the key takeaways for you.
I think the primary tension that's still defining the DNP role is that gap between the defined comprehensive curriculum, the essentials, and the fluid, evolving practice reality. While the degree promises systems-level change, organizational inertia often limits the graduate's immediate impact on those big initiatives.
However, the data confirms the degree's immediate, undeniable value where it really matters most, at the point of care and in translating science.
Exactly. The DNP degree successfully enhances EBP capacity, it improves the ability to translate evidence into actionable change, and it significantly strengthens collaboration within interdisciplinary teams. The ultimate long-term value will rest on the measurable evidence that DNP graduates improve health, provide leadership for system-wide change, and generate that crucial transferable practice knowledge.
So if you are a clinician out there and you're contemplating this significant investment, what is the most important piece of advice based on our analysis?
First, you have to recognize that you're investing not just in a degree, but in an expansive perspective. Keep an open mind. Use the degree as an opportunity to expand your horizons. And second, and this is the most important part for your financial ROI, when you're negotiating new roles and compensation, you must be able to articulate clearly how the DNP provides a return on investment above and beyond the MSN.
Don't rely on the title alone.
You can't. You have to demonstrate the value in systems improvement, in quality metrics, and in measurable outcomes.
That is a vital, actionable piece of advice. And now for our final provocative thought for you to chew on.
I think nursing has to be extremely careful not to fall into the trap of protectionism, which has historically plagued organized medicine as it resisted expanded APRN practice. Constraining the DNP role by refusing to acknowledge its scope or by limiting full practice authority is ultimately counterproductive to society's health. The DNP should be viewed as a springboard, a launch pad for careers that are constantly expanding and innovating. The profession best serves society by celebrating the richness and diversity of its highly educated workforce and ensuring that they are always permitted to practice to the fullest extent of their knowledge and competence. That freedom, that's the only way to realize the full disruptive potential of the DNP in modern healthcare.